Okay. So first of all, I will be going through the latest classification of seizure and then how to approach a patient with seizure when you see in the emergency or in the OPD. So how you take the history and how you evaluate the patient. Then what you do with a first seizure. So if there is a first episode of seizure, how do you manage this patient, whether you'll start the medications or not? Then how do you choose the medication? Which drug is the drug of choice in various type of epilepsy? And how to add the medications? What are the side effects, common side effects of medications? How long to continue the medication, which is a very important question. And then I will take three special situations. One is epilepsy in pregnancy. So I'll be speaking just a few words about how to choose the medications in pregnancy. What are the issues with pregnancy? Second is in the elderly population, which we commonly see late onset epilepsy, how you manage late onset epilepsy, and also epilepsy and psychiatric disorders. So briefly, three special classes of disorders we'll choose in this. So going to the ILE classification, this is the latest 2017 classification. So there are 5 things which we have to be aware of. Whenever we see a patient with epilepsy, we have to classify these 5 topics. So first of all, you have to be sure that it is epilepsy and not a non-epileptic attack. So a pseudo seizure or a non-epileptic attack will not come into this classification. So once you are sure it is a seizure, then you have to decide whether it's a focal seizure or it's a generalized seizure. So focal seizure means a seizure which starts in a part of the brain and spreads to the other parts. So there may be aura which the patient may remember, or there may be some focal jerking, so which may tell us that there is a focal onset of epilepsy. Now, if there is a focal seizure, then you have to find out whether it's in which lobe it is occurring. So whether it's an occipital lobe onset epilepsy, whether it's a medial temporal, whether it's a lateral temporal epilepsy, whether it's a frontal lobe seizure. If it's a frontal lobe seizure, whether it's a prefrontal seizure, whether it's anterior prefrontal, posterior prefrontal, all this can be found out by the semiology or by doing the video EEG. So I'll not discuss into detail, but you have to classify which part of the cortex the seizure is occurring. So that is one thing. Second, if it's a generalized onset seizure, then usually the aura will be not there, and then there will be a sudden onset of generalized tonic-clonic seizures. So that we have to find out. Sometimes it may not be possible with the history of the video EEG to find out whether it's a generalized or focal onset seizure. So then we put it as an unknown onset of seizure. Then second thing is epilepsy type. So after that, we find out what type of epilepsy it is, whether it's a focal epilepsy, whether it's a generalized epilepsy, whether there is a combined focal and generalized epilepsy, or whether the onset is unknown. So after doing the seizure type, the epilepsy type, we try to see whether we can fit into an epilepsy syndrome. Now, why is it important to find out whether there is an epilepsy syndrome? It is very important because suppose you take, if you are dealing with a West syndrome, if the child is having infantile spasm, and then there is the background activity is slow, and then there is history of mental retardation or developmental delay, then you know it's a West syndrome. So that syndrome will prognosticate the illness. You know that the illness is going to be bad, and then you have to give the patient steroids or ACTH. Suppose if there is a tonic seizures and polymorphic myoclonic seizures, absent seizures, generalized tonic-clonic seizures, and the classical tonic seizure, and there is mental retardation and develop neuro regression, then you know that it is a Lennox-Gastaut syndrome, and there is slow wave and spike in the EEG. So that tells that it's a Lennox-Gastaut syndrome. So that again gives a bad prognosis. If you get early morning myoclonic jerks and generalized spikes and polyspikes in the EEG, then you know that it's a juvenile myoclonic epilepsy if the age fits into. So then you are sure that the patient is having going to have a good prognosis, and also the patient is going to respond to treatment well, and also the treatment has to be continued probably lifelong. So that is the importance of knowing the epilepsy syndrome, that is to prognosticate the patient, to start the right drug, and also the duration of the treatment can be analyzed according to the epilepsy syndrome. Sometimes it may not be possible to find out what epilepsy syndrome the patient is fitting into. So then it is okay, then you do not go to the epilepsy syndrome step. After that, this is the new thing which the classification has added. You have to try to find out the etiology of the seizure. So there may be a structural etiology like a old stroke, a tumor, or some AV malformation, or a congenital developmental malformation. It could be some genetic epilepsies, as we know that now gene studies are coming into play. So then you may be finding out a genetic epilepsy like a Dravet syndrome, that is the sodium channel 1 mutation. It could be infectious or post-infectious syndrome. It could be a metabolic syndrome like a GLUT1 deficiency, which is giving rise to the epilepsy. or the immune mediated epilepsy. We know that all the forms of autoimmune encephalitis like NMDR encephalitis or LGI1, Casper, GABA1, GABA A and GABA B all can cause a lot of epileptic encephalopathy. So this could be an immune mediated epilepsy, and then the etiology may be unknown despite all the investigations. So after doing the etiology part, the fifth part is comorbidities. So you have to find out whether the patient is having comorbidities, which may be migraine, which may be some psychiatric disorder, which may be some other medical illnesses. So all this has to be taken care of whenever you are diagnosing a epileptic syndrome. So this has been dealt by Sir. Haldar Sir has told about this. So epilepsy can be focal, generalized, and then unknown onset. So I'll not be going into this. Now, so as I already mentioned, the 5 points are epilepsy type, seizure type, the etiology, and the comorbidities, which can be, there may be associated non-epileptic seizures in an epileptic patient. So both attacks may be there. So you have to pick up the non-epileptic seizures. There may be depression, anxiety, ADHD, migraine, and cognitive impairment, which is maybe due to the epilepsy per se as a part of the epileptic encephalopathy, or maybe due to the medications. So all this has to be taken care of, and also the issue of SUDEP has to be addressed if the patient is having a lot of seizures, continuous seizures, generalized tonic-clonic seizures, and also mental retardation and other comorbidities. Now, these are the examples which I have already mentioned: genetic epilepsy, JME, JE, and then childhood absence epilepsy and Dravet syndrome. And metabolic, you are having PME, mitochondrial disorders, and inborn errors of metabolism. Now, one thing you have to remember is that there may be having multiple etiology. For example, if you think take tuberous sclerosis, it is a structural disorder. So there is tubers in the brain, but there is a genetic defect also there. We know that there is hamartin 1 and 2, the genes are affected. And suppose if you take GLUT1 deficiency, there is a metabolic defect. The glucose metabolism is affected. There is a genetic gene linked also. So there will be multiple factors in the etiology in a single diagnosis. So that we have to take care of. And second is, if you consider genetic generalized epilepsy. So when we are saying it's a genetic generalized epilepsy, so it is genetic and then the seizure is generalized. Then you have to be absolutely be sure about the genetic onset. So unless it is a well characterized syndrome like JME, CAE, or juvenile absence epilepsy or Dravet syndrome, you should not comment on a genetic generalized epilepsy, because once you are commenting, so there can be medical legal implications regarding the marriage, regarding the further children and all. So that has to be taken care of. Unless you are sure about the genetic thing, you should not write it's a genetic epilepsy. So that is one pitfall which they have mentioned in the task commission report of ILA in 2017. Now, how do we approach a patient when the patient has seizures? So first thing is you have to take care of the airway, breathing, and circulation. And second important thing is you have to find out whether there is a severe underlying disorder like CNS infection, meningitis, encephalitis, any metabolic derangement like hyponatremia, hypoglycemia, because hypoglycemia can present with seizure and it is absolutely reversible. And if it is not treated on the time, then there can be permanent neurological damage and drugs toxicity. So these things should be taken care of when there is a first episode of seizure. So when a patient arrives, so first thing is we have to find out whether it's the first episode or whether there is a prior history of epilepsy and whether it's a diagnosed case of epilepsy. So if there is a diagnosed case of epilepsy, then you have to see what triggered the seizure, whether the patient has missed the medicines, whether there was some underlying illness at the time, whether there was sleep deprivation, or whether there was any drug withdrawal or something like that. So the cause has to be found out. If it's the first episode of seizure, then you have to rule out the pseudo seizure and other paroxysmal episodes like transient ischemic attack or syncope, etc. And then second is you try to find out the cause, the risk factors and the precipitating causes, and then try to start the anti-epileptic medication. So I'll go through before doing that, the age of the patient can give us a clue regarding what is the etiology is. Suppose if it's an infant, then the most common cause which we see is perinatal hypoxia or ischemia and intracranial birth injuries. So the birth injuries can give rise to seizures. CNS infection, sepsis can cause. Hypoglycemia and hypocalcemia are notorious to cause seizures in the neonatal period, especially in the first 5 days. and pyridoxine deficiency. So these things will be the common causes in neonates. If you go to children, febrile seizure is the most common cause. Then CNS infections and other metabolic symptoms, syndromes may be the other common causes. In the adolescent and the young adult, trauma becomes the most common cause. And then you are having the genetic causes. Drug abuse is again another common cause. So cocaine withdrawal, then use of various drugs, alcohol withdrawal, all those things can be a common cause there. While in the elderly group, you are having the cerebrovascular accidents. The stroke becomes the commonest cause. Brain tumor, second most common cause. Metabolic derangement, especially renal failure, uremia, and then hyponatremia, and Alzheimer's disease. So late onset seizures are very common in Alzheimer's disease and other forms of dementia. So this thing, the age of the patient will give us a clue what the patient is, what etiology the patient may be having. Then we go through this very common, very important chart from Harrison's, so which tells that if there is history of epilepsy, then you look at the adequacy of the anti-epileptic drugs. You look at the side effects. If the serum levels are available, you have to do the serum levels. Go through the normal routine electrolytes, and if you see that there is a new abnormal change in the neurological examination, then you have to find out the new cause which is giving rise to the seizure. It could be a metabolic disorder, it could be infection, or some structural CNS disorder. So that has to be taken care of. If the other things and investigations are normal, then you have to look at the drug levels, whether the drug levels are subtherapeutic, and then you have to increase the dosage of the drug. If the therapeutic drug level is there, then you have to see about the adequacy of the medications, whether the correct medication has been chosen for the seizure type, and if not, then you have to change the medications or increase the dose of the medication, or you can add on combinations. So that is for a known patient with epilepsy. Now, if there is no history of epilepsy, then you have to be more careful. You have to investigate the patient with routine electrolytes, sodium, calcium, magnesium, and glucose levels has to be done. Renal and liver function tests, and then the metabolic screen has to be done. If there is evidence of fever, neck stiffness, or any focal neurological deficit, so then you have to suspect a meningitis, meningoencephalitis, or some stroke. Then definitely you have to investigate accordingly. You have to do the MRI scan and the CT scan, followed by, if there is clinical suspicion of an infection, then a CSF study has to be done. If all these parameters are negative, you do the MRI and the EEG, and based on the findings, you can start the treatment. Now, this is a flow chart which shows if the patient presents with a possible new onset seizure, you have to see whether it's a seizure or not. So rule out the mimics. And if it is a seizure, you do a physical examination, look for three things: for fever, focal neurological deficit, melted status. If the fundus, you can examine the fundus, you can go for the fundus examination. And if there is some urgent underlying cause, or if it's an acute symptomatic seizure due to a urgent underlying cause, then you have to investigate, do the MRI, CT scan, EEG, as well as the CSF study. If none of these findings are there, then you see whether it's a provoked or unprovoked epilepsy. So provoked epilepsy, you have looked for provoking factors like some medications which has been taken, which has triggered the seizure, some alcohol withdrawal, sleep disturbance, and all those things. If there is a provoking cause, then it's a provoked seizure. Then again, you investigate with a CT scan or a EEG. If there is no provoking cause, then you perform the EEG and the MRI scan and look for the family history and all the prognostic markers. If it is positive, then you have to start the anti-epileptic medications. If all of these are negative, if there's no family history, MRI is normal, EEG is normal, if it's the first seizure, then you can take it as the first unprovoked seizure and then evaluate, and if required, start the medication or follow up the patient and observe the patient. So this is how you can proceed with the first episode of seizure in an adult patient. Now, always remember that MRI scan is better than a CT scan whenever you are evaluating a patient. And again, epilepsy dedicated MRI has to be done. So that has to be mentioned. There is an epilepsy protocol you should write, in which there are certain sequences which they take. And there is also the calculations of the cuts of the slices, which has to be taken in the sagittal, axial, and the coronal images. So that has to be taken. So always specify for a epilepsy protocol MRI. So it has a definite advantage. You can see that the pickup rate is almost 91% compared to a simple MRI. which comes around 39 and 50%. That depends upon the expertise of the radiologist also. So if the radiologist is very well versed in epilepsy, then the pickup rate is 91% for various sort of lesions, because sometimes a focal cortical dysplasia and depth of sulcus dysplasia, it is very difficult to pick up with a normal MRI sequence. So you have to do additional sequences and the thin cuts to find out the underlying etiology. Now, when to initiate anti-epileptic drug? So anti-epileptic drug should be started in any patient with recurrent seizures of unknown etiology or a cause that cannot be reversed. So whether to initiate therapy in a patient with a single seizure is controversial. I'll tell you the various things which we take into account. And patient with a single seizure in which you find that there is an underlying tumor, any infection, trauma, or any remote symptomatic etiology, then definitely you can start the anti-epileptic medication even if there is a single seizure. So that is what, so if there is a underlying lesion or some etiology which is a remote symptomatic seizure, then definitely you can start the medication even if it's a first seizure. Otherwise, if you are having 2 or more unprovoked seizures in more than, with a gap of more than 24 hours, then you can definitely start the treatment. Now, it is seen that with the first seizure, the risk of recurrence is 30%, and with the second seizure, the risk is 70%. So that is why whenever you have a second seizure, we say that we have to start the medication, because the risk of relapse over a period of maybe 1 year is around 70%, while if it is a first seizure, the risk of relapse is 30%. So we wait for yet if the seizure occurs, unless there is an abnormal examination, abnormal EEG or a abnormal imaging, in which case you can start the medications immediately after the first seizure itself. So first seizure, how do we classify the first seizure? So it can be classified as a provoked seizure. It can be classified as an acute symptomatic seizure in which it is due to an acute illness like stroke, traumatic brain injury, encephalitis, meningitis, etc. Or it could be remote symptomatic seizure. So that occurs after 1 week, 1 week later on. So whatever seizure occurs, so that is remote symptomatic seizure. Now, remote symptomatic seizure means the chances of having epilepsy is high. Acute symptomatic seizure means it is due to the acute illness, and usually the chances of developing epilepsy in these patients are less. Now, seizure associated with epileptic syndrome like a JME and other unidentified. So all these are the classification of first seizure. Now, what are the causes of provoked seizure? It can be due to alcohol withdrawal. It can be due to benzodiazepine withdrawal. So patients taking chronically benzodiazepine, suddenly stopping the medication, there can be seizure. There can be metabolic derangements like hyponatremia, hypocalcemia, and hypoglycemia, and hyperglycemia also. So both reduced sugar and high sugar can cause seizure. However, hypoglycemia causes generalized seizure, while hyperglycemia is well known to cause focal seizure. So that is the classical syndrome with hyperglycemia. You get focal seizures. So it is one metabolic disorder which can give rise to focal seizures. Then drugs of abuse, cocaine, amphetamines, phencyclidine, and medications. Medication history is very important. So whenever you get a first onset seizure, always ask history of medications like tramadol, quinolones, and carbapenem group of medications, theophylline, antidepressants like bupropion. All this can trigger seizures. Cough syrups and nasal decongestants for children can cause seizures. So the drug history has to be taken very clearly whenever you get a first episode of seizure. And so what are the causes which tell us that there is an increased seizure recurrence? So that is, if there is a prior brain insult or lesion, for that means remote symptomatic epilepsy. If there is EEG is abnormal, if there is significant brain imaging abnormality, and if it's a nocturnal seizure. So if the patient develops a nocturnal seizure, the chances of recurrence is quite high. So whenever you get these 4 factors, you should think that even if there is a first seizure, you have to start the medications. So these are the indications of starting medication in a first unprovoked seizure. So if it's a prolonged focal seizure, so you are developing focal seizure which is very long. If the first episode is a status epilepticus, so first time seizure and then the patient goes into status epilepticus, definitely you have to start the medication. If there is a focal neurological deficit, mental retardation or cerebral palsy, you have to start medication. If there is a strong family history of epilepsy, if the EEG is abnormal, if the imaging is abnormal, and if there is a high risk job. So if the patient is a pilot, driver, and all those things, you cannot take the chance of further seizure. So definitely you have to start the medication. And then once you discuss, so it is a mutual discussion. If whenever you have a first episode of seizure, you discuss with the patient relatives, and if they are saying that they do not want to take the further risk of developing an epileptic attack, you can start the medication. So that is a mutual decision. So all these points has to be taken into consideration on starting medications in a first unprovoked seizure. Now coming to the treatment. So treatment of epilepsy is multimodal. So it's not about just treating the epilepsy. You have to treat the underlying condition. You have to avoid the precipitating cause, and then you have to prevent seizures and also address the psychological and social issues associated with the epilepsy. So treatment of underlying cause means, suppose if it's a neurocystic psychosis with an active colloidal cyst with edema, so you have to treat the patient with albendazole, steroids, and try to treat this neurocystic psychosis and make sure that the neurocystic circle lesions gets cured. If it's a tuberculoma, you have to treat the tuberculoma, and then the epilepsy also gets treated. So the treatment of the underlying cause is important. Then you treat with anti-epileptic medication to prevent the seizures, and you avoid the precipitating cause. So you have to guide them regarding the lifestyle measures, avoid late night, you have to take the medication properly, and avoid seizurogenic medications and all those things. And most of this epilepsy patient will have depression, anxiety, and a lot of other social issues. So that also has to be taken care of. So all this as a wholesome approach will give us proper treatment to the epileptic patient. Now that there is no fixed treatment plan for as a blanket treatment plan for patient, it has to be individualized depending on the type of seizures, number of the epileptic attacks, the comorbid conditions of the patient, the age of the patient, other medications that the patient is taking. So everything has to be taken into account when you start the treatment. The goal of the treatment is to prevent the seizures and make the patient seizure free without any adverse effect of the medication. So that will be the goal. And usually in 60% of the patients, we can achieve this goal. Rest of the patients, it may be difficult, and then we have to add medications, etc. So what are the issues? So the issues are, is the treatment justified? When to start treatment? How to start treatment? Which anti-epileptic drug we should take? What should be the dose of the drug? When should anti-epileptic medications combination should be used? What are the risks associated with the AD? And how long should we continue the treatment? So these are the questions which come into our mind when we start the treatment. So the major considerations are type of the seizure. So whether it's a focal seizure or a generalized seizure, whether the patient is fitting into epilepsy syndrome, JME, West syndrome, absence, childhood absence or juvenile absence epilepsy, whether it's a Dravet syndrome, whether it's a LGS, whether it's an idiopathic generalized epilepsy. So the type of the syndrome is important. What are the adverse effect profile of the medications which we are using? What is the age and the gender of the patient? So young female patient in the childbearing age group will not start valproate. Similarly, valproate can cause hair loss, polycystic ovarian disease, and then facial abnormalities. Similarly, phentoin sodium can cause gingival hyperplasia and facial abnormalities. So these medications can be a problem in young females. So all the things has to be considered while starting the medication. So what is the ease of use? And what are the specific comorbidities, whether there is migraine, whether there is psychiatric illness, so whether there is obesity, all these things has to be taken into account. And most important is the cost of the patient, cost of the medications. So now we know that the treatment of epilepsy is long. So definitely you have to take into consideration the socioeconomic status of the patient, because the patient has to continue the medications for long. And sometimes it may be lifelong as well. So the socioeconomic status of the patient is also very important. Now, the anti-epileptic medication which we are using should have good efficacy and safety profile, should have a broad spectrum of activity. So if you are not sure whether the onset is focal or generalized, you should use a broad spectrum medication rather than going for a narrow spectrum medication. And it should have a quick action also. So if the patient is having multiple episodes of seizure, then definitely you have to give a medication which has a quicker action, and it should have favorable pharmacokinetics, positive impact on the quality of life. And if it's an elderly patient, there should be a demonstrable efficacy in the elderly patients as well. So we are having a huge armory of medications now, and starting from bromide, which was the first anti-epileptic medication. Now we are having all the newer anti-epileptic medications, and levetiracetam almost 10 years back started on, lacosamide almost 1.5 decades, Now we are having brivaracetam, perampanel, eslicarbazepine, and a lot of new medications which are coming in. So there is a bunch of medications which we can select and then start in this patients. And the mechanism of action, we should roughly know the mechanism of action because it is important when we combine the medications. Because whenever we are combining two medications, then it's better to combine medications having different mechanism of action. So you should know the mechanism of action. For example, if it's in the sodium channel, you are having phenytoin, carbamazepine, lamotrigine, lacosamide, zonisamide, and oxcarbazepine. Lacosamide acts on the slow, fast channels, while the other are not in the slow channels. Then if you are looking at the calcium channel, you are having valproate and ethosuximide. Valproate also has multiple actions on various channels. Action. And then you are having the gabapentin and the pregabalin, which we rarely use as an anti-epileptic agent. We are having the levetiracetam, which acts on the synaptic vesicle 2A protein, perampanel on the AMPA receptor, and felbamate on the NMDR receptor, and then the potassium channel retigabin. So a rough idea on the mechanism of action can be quite useful. Now coming to the most important point, selection of the anti-epileptic drug. So if you are sure about a focal onset of seizure, suppose if there is a definite aura, there is a visual aura, there is a auditory aura, or there is a aura of epigastric rising sensation, you are seeing that the onset is on one side before the seizure spreads to the other side. So then definitely you are sure that it's a focal epilepsy, and the imaging and the EEG shows focal findings. So then the drug of choice for focal epilepsy will be carbamazepine, which is the drug of choice, or oxcarbazepine, which can also be used. Phenytoin, sodium, levetiracetam, zonisamide, brivaracetam, and other agents can be used. Now we should know that valproic acid, lamotrigine, levetiracetam, and topiramate, brivaracetam, these are all broad spectrum agents. So whenever you are not sure about whether it's a focal or generalized epilepsy, you can use a broad spectrum anti-epileptic agent, which are effective in both focal and generalized tonic-clonic seizures. But if you are sure it is a focal seizure, then definitely you can use carbamazepine and oxcarbazepine, which would be the drug of choice. If it's a generalized tonic-clonic seizure, valproic acid will be the drug of choice if it's not a young female of childbearing age group. Otherwise, lamotrigine and levetiracetam would be the drug of choice. And the add-on therapies, you can use phenytoin, sodium, and topiramate, and all other medications. Now, if it is a typical absence epilepsy, ethosuximide, which is available now, is the drug of choice. Sodium valproate is also equally efficacious. Lamotrigine will be the other drugs which can be used. Levetiracetam, being a broad spectrum agent, can also be used in this group. Clonazepam is a very useful add-on therapy for valproic acid in this typical absence epilepsy. If it's an atypical absence or myoclonic seizures, then valproic acid, lamotrigine, and topiramate will be the drug of choice. Now coming to the selection of the anti-epileptic agent. So first thing, there are two variables. One is the anti-epileptic agent related variable. Second is the patient specific variable. In the anti-epileptic related variable, most important is the spectrum of efficacy. So if it's a focal seizure, you can take carbamazepine or oxcarbazepine. If it is a generalized seizure, valproic acid, lamotrigine, or levetiracetam, and the other medications, which broad spectrum medications, can be effective in both focal and generalized epilepsy. Now the adverse effect profile is also important. Teratogenicity is important if it's a young female. Pharmacokinetics, interaction with other medications that the patient is taking, and the cost and availability are important. Now coming to patient specific, the age of the patient, the gender, pregnancy possibilities, comorbidities, co-medications, and individual preferences has to be taken into account. Now certain things, why is it important to know the epilepsy syndrome? Because certain drugs may worsen the epilepsy syndrome. For example, in the myoclonic group of epilepsies like JME, PME, and absence epilepsy, carbamazepine may actually worsen the myoclonus. Similarly, absence epilepsy and PME's phenytoin sodium, the sodium channel blocker, can again worsen the epilepsy. Similarly, benzodiazepine can worsen the Lennox-Gastaut syndrome, and phenobarbital can worsen the absence epilepsy. So if you can have a fair idea of the epilepsy syndrome, you can avoid these medications which can paradoxically worsen the seizure. So now I already mentioned about the anti-epileptic agent. So one important thing is patient advocacy. So that you have to remember. So whenever you are starting a medication, you have to counsel the patient, take the patient in your consideration and talk with them, tell about the possible medications which you can use and discuss and then start the medication. So patient advocacy, like in any other disorder, is quite important in seizure. Try to establish the diagnosis conclusively and try to use the most appropriate agent so that you can control the seizure in almost 70% of the patient. And if initial therapy fails, almost 50% of the patient may not respond to the second medication. So that is very important. So initial response to the therapy is quite crucial. Use a single agent at the lowest possible dose, gradually increase the dose over very gradually, and then use it to the maximal tolerated doses till the seizure stops or if there are adverse effects. And you should avoid sudden discontinuation of the drugs and combine, if you are combining medications, you should combine with drugs with different mechanisms of action. So I'll show the good combinations which are available. And side effect you should be aware of. So if you start the medication very gradually in low dose and then gradually taper, usually the side effects can be prevented. So how to start the anti-epileptic agents in the new onset epilepsy? Use the first line drug. So you find out whether it's a focal epilepsy, generalized epilepsy, and then start the first line agent. If you're not sure, start a broad spectrum agent. Start at the low dose, gradually increase until the seizure stops or adverse effect develop. If the seizure remains uncontrolled, review the diagnosis. So sometimes the diagnosis may not be correct. So it may be a pseudo seizure which you are treating. So find out the diagnosis, whether your diagnosis is correct, and look for the underlying etiology. And then if the first medication is not at all effective, then you can substitute the medication and start a second medication, which is the first line in that seizure diagnosis. And if you think that the first medication is partially effective, you can add second medication along with the first medication. And there is no fixed dosage regarding the optimal dose. So it is by a trial and error. You can calculate the ideal dose and the maximum dose, and with trial and error, you have to see what is the optimal dose for this medication. And to avoid side effect, as I already told, you have to gradually titrate the medication. And the increase in the dose should be after an interval of 5 or more T-halves. So you should not rapidly increase the dose. Wait for 5 T-halves and then increase the dose gradually. So these are the various medications which are available. I will not go into the dosage. Brivaracetam is there, which is a new agent. So it can be used in 100 to 200 mg. Start with 50 mg and gradually titrate over 2 to 3 weeks to 200 mg. So it's quite effective, and it has a more efficacy than levetiracetam, and the binding to the synaptic vesicle protein is also 40 times more specific. So it is a good agent which is available now. And then the dose titration, and it has quick action also. Then other medications I think we are quite aware of, we are using it commonly. Lacosamide is a good agent, lamotrigine is a good agent, levetiracetam we are all aware of. So I'll not be going into the dosages of these medications. So the common side effects, as we all know, phentoin sodium, rash, gingival hyperplasia and ataxia, carbamazepine, ataxia, rash and neutropenia, hyponatremia and hepatitis may also occur. Sodium valproate, you have to be careful whenever you are using in females. It may give rise to weight gain, and then PCOD, polycystic ovarian disease, teratogenicity is a major issue, pancreatitis, hepatitis, weight gain, hair loss, all those things may occur. Lamotrigine, rash and Stevens-Johnson syndrome is the most scary side effect. So you have to start very low and then gradually titrate the dosage, which can easily help us prevent the rash or detect the rash as a very early stage. Levetiracetam, the most important side effect is behavioral problems. So it can cause a lot of agitation, psychosis, depression. So always watch out for this symptom. And if the patient is having underlying psychiatric disorder, you should avoid this medication. Topiramate, cognitive issue is the main issue. So they may be having language problems and all those things may appear. Weight loss is a good thing which occurs with topiramate, and renal stone you should avoid. Lacosamide is rare, overall safe, but dizziness may be a side effect. So these are the common side effect which occurs with the medication. So the CNS wise, perampanel, phenobarbital, topiramate. So this can cause psychiatric issues. So you should be careful with this. Lamotrigine and lacosamide and carbamazepine. So these are having mood stabilizing properties. Also sodium valproate. So this can have a positive effect on the mental health of the. Now, looking into the comorbidity is very important. Suppose if you are having an obese patient with epilepsy, so it's better to start with topiramate or zonisamide because there can be weight loss, and avoid sodium valproate in this patient. If there is osteoporosis, patient with recurrent fractures, so definitely it's better to avoid phenobarbital and phenytoin sodium because that affects the bone health. Cognitive issues, avoid topiramate because this can cause cognitive slowing and language difficulties. If the patient is having migraine with epilepsy, definitely topiramate and valproate will be the better choice because both the illness can be treated together. Renal stones, you avoid topiramate and zonisamide because both of this can worsen the renal stones. Hyponatremia, carbamazepine and oxcarbazepine should be avoided. And if there is any history of rash, so the common drugs which can cause rash is lamotrigine, carbamazepine, phenytoin sodium, and phenobarbital. So this medication should be avoided if there is history of a rash. Now, psychiatric illnesses, depression, anxiety, and all these illnesses, you avoid levetiracetam, phenobarbital, and perampanel. The new agent should be avoided because this can worsen the psychiatric symptoms. And if there is bipolar mood disorder, 3 drugs may be quite effective: carbamazepine, lamotrigine, and valproate because they are having mood stabilizing property. So this I have already mentioned. Now here one thing is older patient, lamotrigine may be a better agent, and Asian you should avoid. It's said because of the HLA association there may be higher chances of Stevens-Johnson syndrome and chronic pain syndrome. So if there is neuropathic pain along with epilepsy, then carbamazepine and lacosamide. For example, if there is trigeminal neuralgia and other neuralgic pain along with epilepsy, carbamazepine and lacosamide may be good agents because they can control both of them. And migraine I have already mentioned. Now, what is the difference between newer anti-epileptic agents and older anti-epileptic agents? So one thing we have to remember is that regarding the efficacy, newer and older anti-epileptic agents are almost same. So there is no difference. It's not that the newer agents are more potent. The older agents like phenobarbital, we know that are quite potent with good control on the seizures. The only thing is that the side effect profile. The newer agents are better tolerated than the older agents, and the drug interaction with the other medications. Suppose if the patient is on medications like warfarin and anti-tuberculosis medications or a lot of other medications, then definitely the newer agents will have less interaction with the other older medications. And also pregnancy. So pregnancy, newer agents are having a better safety profile. Otherwise, efficacy wise, newer and the older agents are having similar properties. Now coming to what is the success with anti-epileptic drugs. So you should remember that first drug, the seizure freedom is almost 50%. When you add the second drug, you can control the seizure in almost 36% more. And after that, the seizure control reduces drastically. So if there is third drug, 13% control, 4% control, and seizure freedom with the second drug is 13%, and 36% of the patient will not get seizure freedom. So almost you can control 70%, almost 65 to 70% of the seizure with the medications. And the more the drugs you add, the more chances of seizure control becomes lesser and lesser. So this is the flow chart which shows that first monotherapy trial, almost you control 47% of the seizures, and then second monotherapy, next 14 to 15%. And third monotherapy or polytherapy, you will control 4 to 5% more. Rest of the seizures become refractory, and then you need help of epilepsy surgery, vagal nerve stimulation, ketogenic diet, and all those things to counter the other parts of the epilepsy. So what are the causes of resistance? So whenever you say that a seizure is becoming refractory or resistant, then you should take into consideration these points. First is the wrong diagnosis. Sometimes it may be some paroxysmal non-epileptic event or some migraine with some epileptic attack which is mimicking the seizure. So you have to get the diagnosis correct. Second is a wrong drug. So maybe you have started some wrong medications. You have started carbamazepine for myoclonic epilepsy, or phenobarbital for absence seizure, which is causing the worsening of the epilepsy. Third is the wrong dose. Suppose you are giving a very low dose, so which is not causing a therapeutic benefit to the patient. And wrong lifestyle. The patient is not taking the medication correctly, missing the dosage, or is not sleeping well, or is taking some alcohol and other medications. So this All these things has to be taken into consideration whenever you say that the patient is having a resistant epilepsy. So this is called as pseudo resistance. So these 4 things has to be taken into consideration. So this I have already told. So if you are suspecting refractory epilepsy, then you can try a combination, and the combination should be using other mechanism of action. So if you have a syndrome, you try the first line agent for that syndrome, or whether it's a focal or generalized seizure, you try the first line agent. If it's not working, you add another first line agent for the syndrome, and continue the medication for some time, and then see if the patient doesn't respond, then you can add the third medication on top of the dual therapy. So these are the things which we consider whenever you combine medications. You establish the optimal dose of the baseline agent, add drug with multiple mechanisms, avoid combining similar mode of actions, titrate the new agent slowly and carefully, be prepared to reduce the dose of the original drug, replace less effective drug if response is still poor, try a range of different duo therapies, and the third drug is added if there is a suboptimal response. And if you see that there is no response to 3 medications, then definitely you can go for the management of refractory epilepsy, and then evaluate the patient with all the other further investigations like video EEG and other evaluations. So these are the mechanism of action which I've already mentioned. So you should combine different mechanism of action whenever you are taking the medications. And these are the various good combinations you can think of. Suppose if it is valproate and lamotrigine, that's a good combination because there is synergistic action. Valproate, being an enzyme inhibitor, increases the level of lamotrigine, so which may be having a synergistic effect. Valproate and clonazepam is a good agent. Valproate, levetiracetam is a good combination. Lamotrigine and topiramate is a good combination. For partial seizures, carbamazepine and clobazam, carbamazepine and levetiracetam, levetiracetam and clobazam, and levetiracetam and lacosamide are good agents. And the age-old combination of phenytoin and phenobarbital are also good for partial seizures. Bad combination is 2 sodium channel blockers like phenytoin, sodium, and carbamazepine together, or phenobarbital and clobazam together. So these combinations are not good. Now, regarding lamotrigine and valproate, you should be very careful when you are combining them. So if you are giving lamotrigine, you are optimized the dose, and then you are adding sodium valproate, then you should cut down the dose of lamotrigine to almost to 33%, because the dose effective serum level will go high because of the inhibition of the valproate. Similarly, if you are the patient is on valproate and then you are adding lamotrigine, then the dose should be at least 1/3. So you should not go in a very high dose. Now these are the various interactions which may occur with the medication. So the older medications are all enzyme inducing medications. So they can reduce the drug level, like the lamotrigine levels, topiramate levels may be reduced. Similarly, zonisamide and oxcarbazepine levels may also go down when they are used with phenobarbital or phenytoin sodium. So these things has to be taken care of. While with the newer agents like levetiracetam, this the drug level doesn't get affected. So the drug interaction potential is also higher with the older agents like phenytoin sodium, carbamazepine, phenobarbital, and valproate. While with the newer agents like levetiracetam and lamotrigine, etc., the drug interactions are a bit less. So these things are, again, whenever you are using other enzyme inducing drugs like rifampicin and other agents from the anti-tuberculosis drugs, diuretics, etc., then the medication levels may go down. So that also has to be considered whenever you are treating a patient who is already on polytherapy for other illnesses. Now coming to the crucial question, when should we discontinue the medication? So there is no specific rule for discontinuing the medication. There should be seizure control at least for 1 to 5 years. This is a range, and there should be a normal neurological examination, no mental retardation, no family history of epilepsy, and a normal EEG. So these are the basic things which should be considered. So the rule is the anti-epileptic medications should be continued at least for 2 to 4 years. So if it's a child, it can be stopped after 2 years, and in adult, it can be up to 3 to 4 years. The reduction of the dosage should be very gradual over a period of 2 to 3 months. So it should not be reduced suddenly. You should taper the dose and should reduce it over a period of 3 months. So these things has to be taken into mind whenever you are stopping medication. So if it's a syndrome with a high probability of self-remission, for example, Beck's. So So benign Rolandic epilepsy, you know that it's a age limited epilepsy, and once the child grows, the epilepsy subsides. Similarly, the gestalt and the Panatopolis syndromes. So these are again age related. Childhood absence epilepsy, this is again age related. So this will subside on its own. So here long-term antiepileptic agent is not required. You can safely stop the medication after 3 to 5 years. And while in the case of juvenile absence epilepsy and JME, you know that it's a lifelong disorder. So here you may have to continue the medication, low dose medication, probably lifelong. So that depends upon the epilepsy syndrome. So this is a study which shows that the various factors which can affect the anti-epileptic withdrawal. So they have seen that the most important predictive factors for relapse are symptomatic etiology and presence of neurological deficit or mental retardation. So if these factors are there, then definitely you have to be careful while reducing the medications. And this is a meta-analysis published in Lancet in 2017, which says that the epilepsy duration before remission, the seizure-free interval before the drug withdrawal, the age of onset of epilepsy, the history of febrile seizures, number of seizures before remission, absence of self-remitting syndrome, developmental delay, and EEG abnormalities. So all this has to be taken into consideration, and which are the seizure predictors whenever you are stopping the medications. So this is from Continuum, which gives us favorable and unfavorable group of people where you should be careful. So if the age of the onset is greater than 10 to 12 years, if there is a symptomatic etiology, mental retardation, abnormal neurological examination, if it's a JME syndrome, it's a symptomatic partial epilepsy, if there was poor response to initial antiepileptic agent, and when if you had needed more than one medication to control the seizures, if there were EEG abnormalities, and if there is a family history of epilepsy, then you have to be very careful wherever you are, whenever you're trying to stop the medications. While if it's a childhood absence epilepsy, Beck's, infrequent seizures, single drug in which you were able to control the epilepsy, normal mentation, idiopathic etiology, then you can be normal neurological examination, you can be quite sure regarding tapering and reducing the dosage of the medication. So I'll go to the pregnancy thing. I'll just cover this very quickly. So pregnancy, we know that the absorption of the drug, the distribution of the drug, the metabolism of the drugs, and the excretion all changes. So the major change in the drugs are in lamotrigine, levetiracetam, oxcarbazepine, where there is more than 50% changes in all these mechanisms, and so the drug level fluctuates. While for carbamazepine and valproate, it is quite less, and for phenytoin and topiramate, it is modest. So because of the changes in the drug metabolism, there may be changes in the dosage, which has to be taken care whenever a female gets pregnant. So this is the first issue. Second important issue which we all consider is teratogenesis. So in a pregnancy, whenever a pregnancy occurs, you should use extended release formulations rather than frequent dosage. So you can use twice dosage. If there is vomiting within 1 hour from taking the antiepileptic agent, you should give a redose. Do the teratogenicity scans and the ultrasound scans in the second trimester. Discuss the peripartum and the postpartum issues at the third trimester. And during the peripartum management, when the lady is admitted in the hospital, ask them to take the medication to the hospital, because most of the medications will not be available, and then that creates a lot of issue. Epidural anesthesia may be quite useful, and lorazepam should be available during the labor. So these things has to be thought of. Postpartum period, you have to take care about the sleep of the lady, because due to the breastfeeding, the sleep may be affected, which may again trigger the seizures. Postpartum depression has to be taken care of, because the drug compliance may be affected by the depression. And again, safety precautions with the newborn, the drug side effects of the newborn has to be taken care of, and confirm the postpartum contraception as well. Now coming to the most important aspect of pregnancy, teratogenicity. We know that it's a dose dependent thing. So valproate being the most teratogenetic drug. So more than 1500, you can see it's around 25% teratogenicity. So that is very high. And if it's a lower dose, less than 700, it comes down to 6%. So it's a dose dependent. So whatever drug you are using, use in the lowest possible drug. Avoid multiple drugs. So you should try to use single agents whenever you are using in pregnancy, and avoid sodium valproate. Valproate can be given, but it should be in very low dose, preferably less than 600 mg. If the patient is in a valproate responsive, exclusive valproate responsive epilepsy and well controlled on sodium valproate, then less than 600 mg of sodium valproate should be given to the patient. Carbamazepine, again, the tetrogenicity is less. Phenobarbital, it is high, and lamotrigine, it is less. So this is the comparison of the various European, North American. This is the UK and the Ireland registry, and this is the Kerala registry. This is the registry from India. So you can see that lamotrigine has very low tetrogenicity, followed by carbamazepine, and valproate as the highest. So this shows the comparison. I'll show you here. This shows the comparison, and this says us that levetiracetam, lamotrigine, carbamazepine. So these are these three safest drugs which can be easily used in pregnancy with least tetrogenic effects. So this is a chart which shows that lamotrigine, levetiracetam, carbamazepine. So these are the safest options, followed by oxcarbamazepine, and then phentoin sodium, phenobarbital, and valproate being the most drugs with the most congenital malformations. Now, it is not just the congenital malformation. So the AEDs affect the neurodevelopmental outcome also. So there's a study called as a NEED study which shows that high dose valproate can cause affects the IQ of the child. And not only this, it causes autism and autism spectrum disorder. So sodium valproate and other medications like carbamazepine, lamotrigine, etc. in high doses can give rise to autistic trait in the children. So it's not just about the organ development. It can affect the IQ, long-term, the mental capabilities, as well as traits like autism and autism spectrum disorder. So this is a summary. I think I'll skip this. And second is regarding the contraception. Whenever you are using in females, there is potential interaction of carbamazepine, phenobarbital, and all these agents with the contraceptive pills. So the newer agents like levetiracetam and sodium valproate also has less interaction with the contraceptive pills because of the enzyme inducing agents. Now, if the lady is on lamotrigine, the oral contraceptive pill may reduce the lamotrigine levels as well. So there may be chances of seizure precipitation in patients who are on lamotrigine with contraceptive pills. So all these things has to be taken care of, and you should be in close communication with the gynecologist regarding the issues of contraception whenever these patients, female patients with epilepsy are being treated. So this is the effective contraception which can be used: barrier, Mirena, and Depo-Provera. So these are the safer options which can be used in this women taking enzyme-inducing anti-epileptic agents. Now coming to perimenopause and menopause. So women with epilepsy who are having a history of catamenial pattern, so they can have a worsening of the epilepsy once the menstruation stops. So that is perimenopausal worsening. Second, the use of hormonal replacement therapy can also increase the seizure frequency. So this has to be taken into account. Third is the bone health. So enzyme inducing agents like phenobarbital, phentoin sodium, carbamazepine, etc. So it may affect the bone health. So the best medications which do not affect the bone health is levetiracetam and lamotrigine. So usually these are the safer options to be used in the elderly female population post-menopause. Now epilepsy in elderly, we know that in the elderly, stroke, dementia, these are the common etiology. So a lot of patients will be treating who are having epilepsy in the elderly. So one thing is very important. In elderly population, the semiology of the seizure is different. So similar to the neonate, in which the semiology is different, children, the semiology may be different. Similarly, in the elderly population, the semiology may be different. There may be no epileptic aura. There may be no GTCS. It may just present with fluctuating cognition and all those things. You may not get the complete jerking. So these things has to be kept into mind whenever you are taking the history. So it may require a very high clinical suspicion to diagnose a typical seizure in an elderly population. So these things has to be kept into mind whenever you are having treating the elderly people, because they are very weak, they are fragile, the protein levels are low. There may be having multiple medications which may have interaction with the anti-epileptic medications. Bone health is an issue. Cognitive involvement is an issue. So many things is there. So you have to be quite careful whenever you are treating this patients. So depending on this study, they have found that lamotrigine, levetiracetam, carbamazepine are the good agents which can be used in the elderly population because which are having less cognitive effects. So lamotrigine is found to be quite useful in the elderly population. while the other agents like pentoin sodium and zonisamide and sodium valproate are not much safer in the elderly age group. So these things I'll skip. So renal failure, you should be aware, see the dose modifications and all. So renal failure, you know that levetiracetam is renally excreted. So you have to reduce the dose if there is a renal failure, and you have to give additional dosages after hemodialysis. So that thing has to be remembered. So renal failure patient on levetiracetam or renally excreted medication, the dialysis may wash out the medication and there may be precipitation of the seizure. So you have to give the additional dosage per dialysis. And then the dose reduction has also to be done according to the GFR, which has been mentioned in this chart. So that thing has to be kept into mind. And this is the final slide. So in psychiatric patients, most of the patients may have psychiatric illness along with epilepsy. So depression patients, you give antidepressant. So you should avoid antidepressants like bupropion and amoxicillin, which may precipitate the seizures notoriously. So the recommended drugs are citalopram, sertraline, and you should avoid phenobarbital, pentoin sodium, and topiramate, etc., which may worsen the depression. So these will be the recommended drugs: carbamazepine, lamotrigine, oxcarbazepine, valproate, so which can be used in depressive patients. In anxiety patient, you should avoid levetiracetam, which may worsen the anxiety, and better to use benzodiazepine, sodium valproate, etc. And psychosis patient, again avoid levetiracetam and topiramate because it may worsen the psychosis. Similarly, psychosis patient, you should not use clozapine or chlorpromazine because this may precipitate the seizures. So that has to be taken care of. Psychosis, lamotrigine and valproate and oxcarbazepine will be the drug of choice. And finally, if there is no response to the medications, you evaluate the patient with a pre-surgical evaluation, which includes video EEG, neuropsychiatric evaluation, functional imaging, invasive monitoring, referring to an epilepsy center. And various epilepsy surgeries are available. If there is a lesional epilepsy, there may be directive resective surgery, disconnective surgeries, lesioning, and then deep brain stimulation of the anterior thalamus has also been found to be quite useful in refractory epilepsies. So all these things, ketogenic diet in children, so all these things can be used in judicious management of epileptic patients. So I think I'll conclude with this slide. So AED should be started if there are 2 or more unprovoked seizures or first seizure in selected patients. Choose the drugs based on the seizure type, epilepsy syndrome, comorbidities, age and gender. Try continuing the medications for 2 to 3 years, and then select the patients and discontinue the medications over a period of 2 to 3 months, taper and stop. Planned pregnancy and continued anti-epileptic medications in pregnancy in the minimal possible dosage, preferably monotherapy with folic acid is what is recommended in pregnant patients. So I think we can conclude here and then we can take the questions.